a 28-year-old para following a cesarean section. She developed on the fourth day, she developed restlessness, abnormal behavior, and referred to her institution. And this is the picture. Dr. Hephzibah, are you there?
Yes,
Dr. Hephzibah? Yeah. Yes, go on. How do you comment on this particular case?
I sincere thank to Dr. Pujimagi, Professor Lakshmi Ammal, and then Professor Rajshekharan. I think this case is a case of based on the history because the LSCS was done for PRO for 14 hours, and she has developed all these symptoms after 4 days. So I think based on the history and the clinical features of shock and altered sensorium and the laboratory findings, we should make a diagnosis of septic shock with the multi-organ dysfunction, especially acute kidney injury and the liver. Actually, I think it's very easy to pick up a diagnosis of sepsis when something goes just beyond the base. So there are the criteria, the 7 criteria are there to find out whether the sepsis has set in, but 2 out of them is very important. Even if there is a two criteria, we have to suspect sepsis. And once you suspect sepsis, we have to find out who will require an intensive therapy or not. That also we have a quick assessment for organ failure assessment. Immediately once we suspect sepsis, see when it is uncomplicated sepsis, it's very easy to treat. When it becomes severe sepsis and septic shock, the mortality is 50%. So once the patient is in shock, quickly we have to resuscitate with the tip that is which we have a sepsis 6 bundle. Like any other shock, we have to resuscitate them with administer of high flow oxygen. Here, the important thing we have to take a blood culture before giving an antibiotic. The antibiotic should be broad spectrum and it should cover both aerobic and anaerobic. And we have to resuscitate with IV fluid because there is a shift. And we have to check for hemoglobin and serial lactates, and of course, watch on the urine output. Our goal is during resuscitation, we should aim at to get a CVP of 18 to 12 and mean arterial pressure more than 65, urine output 0.5 ml per kg per hour, and that central venous oxygen should be 70%. We should aim at clearing the lactate. So the main important thing here is within an hour, we have to resuscitate. The IV fluid should be either a normal saline or this thing, and never give a start. And it should be 30 ml per hour, and it should be fed over 3 hours. And we should combine it with vasopressor. The first line will be adrenaline, noradrenaline. If needed, a vasopressor and norepinephrine can be added. And here, this patient, we need to have a renal replacement therapy. And of course, the venous thromboembolic prophylaxis should be given. If the hemoglobin level is less than 7, we have to give blood transfusion. If to restore reverse the shock, if she's not reversing with all this medication, we should combine it with hydrocortisone 200 milligrams per hour. So to reduce the mortality in a case of septic ischemic shock, so we have to recognize the shock early and initiate the broad spectrum antibiotics, fluid resuscitation with the vasopressors, and if it is to reverse it quickly, we may have to give a hydrocortisone 200 milligrams so that we can reduce the mortality. Thank you.
Thank you.
Thank you.
In fact, thank you, Dr. Hephzibah, for highlighting the important thing. That is, you have highlighted that the sepsis is a time-sensitive disease, and you have to identify this quite early before the patient develop pus and fever and all those things. So look for the early warning signs. So thank you very much. And in fact, there are other causes for collapse, inversion, aortic dissection, so many things are there. But I am afraid that we don't have any more time. What about?
Yes, sir. We are already
yeah. I think this is the right time to wind up. So we should find that the maternal collapse is a rare but life-threatening event, and in all situations of collapse, the response should be very quick and it should be adequate. Then it should be following protocols. And in fact, there are so many other dimensions for collapse. That is, it produces a crisis situation, even a law and order situation in some of the situations. And all of us as professionals will have to minimize the aftermath. Otherwise, what will happen is that we may land up in a medico-legal conflict. So involving the relatives, documentation, all those things are of prime importance, just like the scientific management of the patient. And I take the opportunity to thank all the panelists for bringing out the gist of that particular problem in an excellent manner. Thank you very much. Thank you, Dr. Bunyamoideen. Thank you, Dr. Wahab, then Mumtaz, for this excellent opportunity. Thank you.